Before going for main presentation, I want to give a brief history why I choose this topic to present in this prestigious forum. So, in a country of having limited number of neurosurgeons like Bangladesh, where 350 neurosurgeons only supporting a country of having 172 million population. So just after post-graduation, a young neurosurgeon have to go for a number of spine cases, among which surgery for prolapsed lumbar intervertebral disc is the most common one. So preoperative assessment regarding the diagnosis from neuroimaging bears a paramount importance for surgical decision-making and patient's outcome. So my today's topic of discussion will be mimics of prolapsed lumbar intervertebral disc, a diagnostic and management challenge to a spine surgeon. So this is the brief overview of my today's presentation. Like at first, I will give a brief overview of anatomy of the human spine, and later on, what is prolapsed lumbar intervertebral disc. After that, there will be a short literature review of the prolapsed lumbar intervertebral disc mimics. And after that, I will share my own experience by giving some representative cases. And lastly, I will put some imaging tips and tricks for the young neurosurgeons so that they can easily diagnose the typical prolapsed lumbar intervertebral disc and can differentiate it with their mimics. And lastly, there will be take-off messages for all. So this is the schematic picture of human spine. The human spine is a osteoligamentous structures. There are 33 vertebrae, which encloses a spinal canal. So in the spinal canal, there is spinal cord, through which in each segment, there is exiting of two spinal nerves on both sides. And between two vertebrae, there are intervertebral discs, and it is composed of nucleus pulposus in the center, and in the periphery, there is annulus fibrosus, that is a tough structure. So there are some predisposing factors by which this healthy disc undergoes degenerative changes like aging, obesity, strenuous physical exercise. There may be presence of family history or history of smoking. So these are the common predisposing factors which causes degenerative disc diseases. So at the for initial stages of degeneration, I put a schematic picture on the left side. That is, there is wearing and tearing of the annulus fibrosus, which causes later on herniation of the nucleus pulposus through this tearing. And what is the result? There is this herniated disc material acts as a foreign body in the spinal canal. So with the course of time, there is progressive inflammation in the local milieu. So together, the herniated disc material and inflammation causes severe pain and compressive effect of the neural elements, that is to the spinal cord, conus medullaris, and chorda equina. So if we classify the types of disc herniation, anatomically, it can be classified into 4 types, like bulging disc and protrusion, extrusion, and sequestration. So in the first 2, like bulging disc and protrusion, there is relative preservation of the annulus fibrosus. You see there is a intact annulus fibrosus, the outer boundary remains intact. But what happens in the extrusion and sequestration, there is breaching of the annulus fibrosus through which there is herniation of the nucleus pulposus outside through the boundary of the annulus fibrosus. And this extruded disc can lost its connectivity with the mother nucleus pulposus. It can remain at the same level when it is named as sequestered disc, and it can be migrated anywhere in the spinal canal craniocaudally. So radiologically, considering the position of the herniated disc, it can be classified into 4 types, like central, that is defined, characterized by blue, Subarticular or paracentral marked as red. That can be foraminal disc herniation marked as yellow, and it can be extraforaminal marked as orange color. So the presentation is different considering the position of the herniated intervertebral disc. Usually central and paracentral, that causes compression of the traversing nerve root, and foraminal and extraforaminal, that causes compression of the exiting nerve root. So the clinical manifestation differs from central with paracentral to that of foraminal and extraforaminal herniated disc. So what is the common clinical presentation of PLID? We all know that. I don't go in details. Just in summary, I want to say that in lower lumbar region, it can be presented as a features of radiculopathy, and in extreme level can be presented with the features of chorda equina. But what happened in the upper lumbar disc herniation, it can be presented as conus medullary syndrome or can be manifested as chorda equina syndrome. So there are some clinical features which can suggest PLID, but these features not sometimes confirmatory to prolapsed lumbar intervertebral disc, it is only suggestive. Like from history, this prolapsed lumbar intervertebral disc usually affects the middle-aged population. And from history, there may be presence of smoking history of trauma to the back, or heavy weightlifting. And for my country, it is commonly seen in the household workers. So if we look at the characteristics of the pain is intermittent in nature, usually radiating, that is aggravated after coughing, sneezing, straining, and forward bending, and usually decreased in lying posture and sometimes with medication. And if we go for detailed neurological examination, the classical sign is restricted straight leg raising test. That will be 60 degrees or less. And in upper lumbar disc herniation, femoral test become positive. And if we look at the picture, that is the classical sign of a position of a patient with huge herniation of lumbar disc. That is, sometimes scoliosis may be present, which is obliterated in forward bending. That is termed as LIST, that is functional scoliosis. The gait is typically antalgic. Sometimes in case of steepage gait can be present. Okay. Jerk usually diminished or absent, and plantar is flexor. So classically lower motor neuron type of features we can found. Okay. So what is the common neuroimaging modalities for diagnosis of PLID? We can go for X-ray of the lumbosacral spine. That is only suggestive. This is not confirmatory. To confirm the herniation of the intervertebral disc, we should go for MRI of the lumbosacral spine with or without contrast. So contrast can be given to rule out its mimic. So if sometimes MRI become contraindicated, say patient having pacemaker or some valve surgery, that is not MRI compatible. So we can go for CT scan of lumbosacral spine. We can go for CT or MR myelogram and spinal angiogram in selected cases to rule out the spinal vascular malformation that mimics the prolapsed lumbar intervertebral disc. So now one by one, I will share the suggestive features of prolapsed lumbar intervertebral disc. This is the X-ray of lumbosacral spine, AP and lateral view, where it is demonstrated that there is scoliosis, convexity directed towards the right side. And it indicates that the patient may have suffering from herniated lumbar disc. And in the lateral view, it is evident that there is a almost straightening of the lumbar lordotic curvature. So it indicates muscle spasm. And there is reduction of the height of the intervertebral disc at the level of L4-5. So that might be the level of herniated disc. So let us go for the MRI of this patient. So in the MRI, it's evident that there is herniation of the intervertebral disc at the level of L4-5, which was suggestive in the plain X-ray. I have already shown it. And in the axial view, there is right paracentral disc herniation. So what is the features in the myelogram? In the myelogram, there is a filling defect evident in the L4-5 level. So it indicates that there is some kind of compression in the L4 nerve root. So in the MRI, basically what we look for in MRI in case of a PLID patient. So in the MRI, in sagittal and axial view, it's helpful to characterize the types of disc herniation, whether it is central, paracentral, foraminal, or extraforaminal. That is mandatory for preoperative planning. So intensity of the herniated disc, there may be, we can assess annular tear, extent of nerve root compression, relationship with the thecal sac and surrounding structures. There may be presence of flow voids, which can give us clue about the alternative diagnosis. In association, we will assess the mordic change, condition of the ligamentum flavum, facet joint, and associated spinal canal stenosis. So all of the features are important for accurate preoperative diagnosis and planning. So a CT scan of lumbosacral region demonstrated that's another example. If we come to go for MRI, in the CT scan, there is a isodense shadow located in the right paracentral region marked by the blue arrow. This is suggestive of prolapsed lumbar intervertebral disc, which is slightly indenting the thecal sac at the L5S1 level. So this is another example where the left paracentral herniated disc indenting the thecal sac and at the L5S1 level. So this is another example of MR myelogram. In the myelogram, there is cutoff sign at the level of L4-5. This cutoff sign is not indicative of PLID, rather it indicates some extradural lesion. So apart from this prolapse, if there is any extradural pathologies like tumor, there may be similar sign appeared in the MR myelogram. So I am now entering our today's topic, that is what is mimics of prolapsed lumbar intervertebral disc. So in my previous slides, I have already given a general overview of prolapsed lumbar intervertebral disc. So what is mimics? That is for the convenience of my audience, I have divided this entity into two segments. In the first half, I will discuss the clinico-radiological diagnosis is PLID, but intraoperatively, we will detect other pathologies rather than PLID. And the second half, our clinico-radiological diagnosis is pathologies other than PLID, but intraoperatively, surgeons detect lumbar disc herniation. So both condition can mimic PLID. One is preoperatively and another is intraoperatively. So let's enter the literature review, what literature says about the mimics of PLID. So a long list of mimics of PLID that is beautifully explained by Professor Ali Akhdar in his classic book, Atlas of Sciatica, which is published in 2024. I have taken this chart from his book. It's a long list among which some neoplastic lesion, vascular lesion, some infective lesion, cystic lesion, even nerve root lesion and anomalies can mimic prolapsed lumbar intervertebral disc. So let's have a look. So this is the example of a spinal tumor mimicking PLID. So in the imaging, axial imaging, it is evident that there is a right-sided, left-sided, paracentral and foraminal iso-intense lesion that is indenting the thecal sac. And concomitantly, there is a widening of the intervertebral foramina. So it mimics the type of disc herniation, but intraoperatively, there is nerve sheath tumor. So most frequently, non-vertebral tumor mimicking PLID, there are lots of. So most commonly, there's a schwannoma and anterior placed neurofibroma can typically mimic the prolapsed lumbar intervertebral disc. There may have some rare etiologies like lymphoma, myeloma, leukemia, or any extradural metastasis, etc. So this is another example of intradural disc herniation. This is quite different from the classical prolapsed lumbar intervertebral disc because the disc material retained within the dural sac. It has lost its continuity with the parent disc. So it is regarded, though it's disc herniation, but it is regarded as PLID mimic. So here is the example of a 58 years old woman who presented with lumbago for 2 years and right sided sciatica for 5 days. The authors went for L5 total laminectomy, longitudinal incision on the dura, and removal of the disc material within the dural sac. And patient achieved complete neurological recovery at 3 months follow-up. After that, here comes example of conjoint nerve root. Okay, there is a classification of conjoint nerve root. I don't go in detail now. This is the myelogram, which shows the filling defect. If we compare with the left side, the right side, there is a filling defect at the S1 level. And if we go for a CT scan, there is a herniation of the intervertebral disc and some mass is there, which is indenting the thecal sac from the right paracentral position. So in the CT scan, there is not much more information we can gather about the conjoint nerve root. We have to go and take help from MRI. So let's go into the MRI. This is the MRI of the similar person showing there is a herniation of the intervertebral disc with upward migration at the level of L5S1. So in the T288 image, it is evident that there is the disc become hypointense. So it indicates degenerative disc. From typical MRI, it can be said that there is a degenerative disc herniation. But intraoperatively, the surgeon detects the disc become intact and it was conjoint nerve root. So in the MR neurography, at the right side, there is 2 separate nerve root clearly evident here. So the authors went for wide fenestration and removal of the small herniated associated disc in piecemeal fashion, and patient achieved complete neurological recovery in 1 week follow-up. Okay, this is another example of conjoint nerve roots where I have shown a classic sagittal shoulder sign, which can help us to differentiate it from typical disc herniation. So another example of conjoint nerve root in the axial section, if we see that there is a dilatation of the dorsal root ganglia, 2 ganglia here, but in the left side, only 1 ganglia. So it can be a suggestive sign. Okay, sometimes epidural vein that can be mimic from intervertebral disc. This is one of the example. Classically, in the T288 image sagittal section, it is evident that there is herniation of the intervertebral disc at the L4-5 level, which lift up the posterior longitudinal ligament. But in operation, during operation, there was venous bleeding, and authors concluded that that was the venous varix. This is the axial section of the similar patient showing a huge herniated disc. Okay, another example of lumbar epidural varix at the L4-5 level, which classically mimics prolapsed lumbar intervertebral disc, but there is another separate lesion. It mimics that there is downward migration of the intervertebral disc. So authors didn't go for any angiogram, but intraoperatively they noticed that that was venous varix with an intact disc. There was basically no disc herniation. So they went for coagulation of the varix. Sometimes spinal dural arteriovenous fistula can mimic prolapsed lumbar intervertebral disc, where there may not be presence of prominent flowers. So let's have a look for this example. This is a MRI T288 image sagittal section of a 45 years old female who presented with excruciating pain in the right lower limb. So it is evident that there is, from imaging, it mimics that there is disc herniation at the L4-5 level with huge downward migratory component. But if we carefully look, there is some dot-like flow voids, which may have they didn't notice. But intraoperatively, they found that there is fistula and they went for coagulation. So this is another example of spinal dural arteriovenous fistula. It's a rare one. In the MRI, T280 may suggest a section that there is a disc herniation of L4-5 space with both craniocaudal migratory component. It seems like that, but author didn't went for any angiogram, and these findings discovered intraoperatively that the disc become intact, and this is totally arteriovenous fistula. Sometimes ossification of the posterior longitudinal ligament can mimic prolapsed lumbar intervertebral disc. Let's have a look. So this is the T1 and T280 image showing the herniation of the intervertebral disc at the L4-5 level and 5S1 level as well. If we look at the intensity, this is hypointensity, severely hypointensity in the posterior longitudinal ligament. So author went for a CT scan. So in the CT scan, it is evident that there is ossification of the posterior longitudinal ligament, which is clearly evident in the axial CT scan also. So it's a rare example which can mimic PLID, that is spinal epidural abscess. There is the disruption of the material as well as herniation of some of its component is clearly evident in the axial section. So sometimes, very rarely, it can mimic the PLID. This is a rare example of swollen nerve root, where disc remains intact, and intraoperatively surgeon can notice that only the exiting nerve roots or traversing nerve root become hugely swollen. Okay, let's have a look. This is the T280 image sagittal section showing there is a herniation of the intervertebral disc at L5S1 level with the upward migratory component. The upward migratory component has a difference in the intensity with the herniated materials, and in the next section, it seems to be separated from the. So it can, from imaging, we can say that maybe there is a migratory component here. But if we carefully look at the axial section, there is right paracentral mass with an intact annulus. So in the operation theater, it is evident that there is hugely swollen S1 nerve root with intact intervertebral disc. So they concluded that probably previously there was some kind of herniation of the intervertebral disc, but with the course of time, it undergoes spontaneous resorption. And for the inflammatory reaction, these exiting nerve roots become hugely swollen, which mimics the PLID in the follow-up images. So this is another example of swollen nerve root, right S1 exiting nerve root. I have taken it from Professor Ali Athadar's books. Sometimes post-operative foreign body granuloma can happen after this surgery. Very rarely we can forget to remove the cottonoids. So this is one of the example of this kind of incident. Surgeon put a small cottonoid, but forget to remove it after the procedure. So what happened in the follow-up images 10 months after the surgery, there is a mass. In the axial section, it's clear that the annulus become intact, and there is a huge mass in the left paracentral position. And later on, it is diagnosed as a case of foreign body granuloma because of the placement of cottonoids. Sometimes, rarely, spinal epidural lipomatosis can mimic PLID clinically. Basically, radiologically, we can differentiate it easily because fat exhibit hyperintense signal change both in T1 and T280 images. But clinically, patient can come to me with the complaints of lumbago with sciatica. So from that perspective, it can mimic PLID. After that, this is a rare case of postoperative epidural fibrosis. Okay, in the axial section, there is if you look for this yellow arrowhead, there is a left paracentral mass causing compression of the traversing nerve root. So after giving contrast, this mass become enhanced, and in between the mass, there is a circular area. It's actually the nerve root which become entrapped within the peridural fibrotic tissue. So this patient classically mimics the features of PLID. So this is another example of extradural fibrous entrapment of S1 nerve root in a 25-year-old patient, where it is evident that there is previous laminectomy mark at the L5S1 level, and there is herniation of the intervertebral disc. It mimics in T1 and T2 image, but intraoperatively, there is fibrosis present. So I have already concluded my first half of literature review. That is, imaging criteria mimics prolapsed lumbar intervertebral disc, but intraoperatively, the disc is relatively intact and the pathology is other than disc prolapse. So this is my second half. That is, radiologically, we will diagnose the pathologies other than PLID, but intraoperatively, surgeon detect herniated disc materials. So let's have a look. This is the first case. That is a 45-year-old man. He presented with classically lumbago sciatica for 4 weeks. So in the imaging, there is an extradural mass at the L4-5 level. That is intradural extramedullary mass. If you carefully look at the dura mater, it is intradural. Okay. They thought that initially it can be a schwannoma or something like nerve sheath tumor, intradural extramedullary spinal as well. But intraoperatively, histopathology proves that it is herniated disc material. Okay, this is another example of spinal as well at L2-3 level. If we look for the contrast, I have marked the contrast images. It exhibits peripheral rim enhancement. So it can be cystic schwannoma or something like that. From imaging, our impression was like that. But the author intraoperatively detects a huge herniated disc. Another example of a 61-year-old male patient. I have only put the post-contrast images, which shows that there is a rim enhancing lesion or just opposite to the S1 vertebral body. Classically exhibits the bullseye sign. So this is basically a sequestered disc material which mimics some intradural spinal space of occupying lesion. So sometimes this is another example of lateral or foraminal sequestered disc material with upward migration. You have classically seen that there is mass, intradural extramedullary mass, just opposite to the L4 vertebral body. And if we look at the axial section, there is paracentral and foraminal component with widening of the intervertebral foramina. Classically mimics some case of neurofibroma, but intraoperatively, the authors detect it as a herniated and migrated disc material. So long list of differential diagnosis of sequestered disc reported in the literature. This is the list. I don't go going to read this chart. I've already know that. So I put a rare example of spinal epidural hematoma mimicking PLID. This is the patient of 38-year-old male patient who developed features of Cordoicuna syndrome for 4 days following heavy weightlifting, that is 160 kg. And following that, he had a click-like sound and followed by the development of Cordoicuna syndrome, suffered from 4 days, and then came to medical attention. And on examination, his lower limb power was 2 out of 5 with saddle anesthesia with features of acute retention of urine. So in the MRI, there is a iso intensity extending from opposite to the L5 vertebral body marked by the blue arrow, which become hyperintense in the T2 image. And after giving a gadolinium, there is no contrast enhancement. So authors concluded that there may be some kind of epidural hematoma there. So what happened intraoperatively when they go for L5 hemilaminectomy, They removed herniated disc in piecemeal fashion, and this is their intraoperative picture demonstrating the herniated disc. And in the 6-month follow-up, patient achieved 4 out of 5 muscle power with significant improvement of his bladder function. Another case of postoperative discal cyst. This is very rare one. I don't have this kind of report in any literature except the case given in the book of Professor Akhadar. I took here this case from his book. This is the postoperative discal cyst, which become classically hyperintense with a hypointense ring at the L4, L5 level. Patient underwent operation at the similar level. So now I am going to share my experience of the PLID mimics in past 3.5 years. So past 3.5 years, we have experience of underwent almost 300 PLID cases, among which we have detected 25 cases of mimics. That is, our imaging diagnosis was prolapsed lumbar intervertebral disc somehow, but intraoperatively we had detected different kinds of pathology with relatively preserved disc material. So let's have a look. My first case is a 56 years old female patient. It's a known case of pre-diabetes, hypertension, and ischemic heart disease, presented with the features of neurogenic claudication for 2 years. So on examination, I have found that she was neurologically intact, except heel walking and floor walking was not possible due to pain, and patient exhibited classical antalgic gait during walking. So this is the MRI. T1 and T288 image demonstrated that there is herniation of the intervertebral disc at the L4-5 and 5S1 level. But if we carefully look at the T288 image, there is another mixed intensity lesion lies opposite to the herniated disc material. So in the axial images, there is corrugation of the border of the annulus fibrosa with multiple lamelation, and some kind of small dot-like proboids existed in the T288 image. So what I have observed in the operation theater, this is the thecal sac, and after retraction, there is varicose vein with presence of epidural fat, the concentrated epidural fat. So our conclusion was varicose vein. We didn't find any herniated disc materials in both levels. So we just coagulated the varicose vein, and patient improved dramatically. And in the 3 months follow-up, there was no features of neurogenic claudication. Our second case was a 70-year-old male patient who is a known case of diabetes mellitus, hypertension, hypothyroidism. And this patient presented with lumbago for 1 year and bilateral sciatica for 1 month with gait difficulty for last 15 days. So on query, he gives history of trauma to the back 1 month ago. On examination, muscle power was 4 out of 5 in the left side, and SLR was 50 degrees bilaterally. So this is the MRI showing there is a herniation of the intervertebral disc with upward migration in the L2-3 level. But if we carefully look at the axial images, there is a cleft sign. There is a cleft sign between the herniated disc and this extradural mass, which indents the thecal sac and displaces it towards the right side. So what we detect in the operation, basically after retraction of the dura, we didn't notice any disc material. So there is huge swelling of the nerve root, and some kind of mass lies in the thecal sac. We have detected it through our tactile palpation. So we give a longitudinal incision to the dura and found this huge disc material, and we were able to remove all of the disc material intraoperatively, and we go for primary closure of the dura. Some part of the dura we didn't go for primary closure. We kept a smashed muscle patch on the dura mater. Postoperatively, no CSF leakage we have observed, and patient achieved complete neurological recovery at 1 month follow-up. So our next case is a quite interesting case. This case basically did not mimic prolapsed intervertebral disc in neuroimaging findings, but from history, patient came to us with the features of lumbago with left-sided sciatica for 3 months. So if we look for the imaging, there is small herniated disc at the L4-5 level with classical scalloping of the posterior part of the L5 vertebral body. And there is a well-defined hypointensity noted at this scalloping margin with a well-defined margin and cleft-like hyperintensity surrounding the mass. So in the axial image, we were quite confusing about the diagnosis, what it can be. In the CT scan, there is a small linear calcification noted. Apart from this, we have a suspicion that there may be a foreign body, but from history, it has been already ruled out. So from benefit of doubt, we explored the case and go for operation. Okay. In the operation, what we noticed, this is the traversing nerve root. And after retraction of the nerve root, there was a mass, encapsulated mass. But at first, we were confused what it can be. And after a kind of dissection, we have noticed that there is a hugely dilated vein. So we have coagulated their vein as much as possible we can. But despite of adequate coagulation, there was some kind of bleeding. So we put a ball of Surgicel in the cavity and able to stop the hemorrhage. Postoperatively, patient, immediate postoperative period, patient still had some kind of sciatic pain, but the intensity was diminished from preoperatively. And 1 month follow-up, patient had no features of sciatica. So he is still now in our follow-up, strict follow-up, and our plan is to do for spinal angiogram if symptoms reappears. So our next case is a 45-year-old male patient who classically presents with the features of lumbago with sciatica for 6 months, and for last 2 days, pain became worsened and he developed acute retention of urine. So our provisional diagnosis was Corda-Equina syndrome as it is due to PLID at L5S1 level. So from imaging, you have seen that there is herniation with downward migration, and the migratory component lies just opposite to the S1 vertebral body. But in the axial section, we have noticed that the herniated material is somehow bilobed in structures. We have never seen these features in our previously treated cases. So we went for operation, and in the operation, we have detected that it was intradural disc herniation. So just after fenestration, wide fenestration, we have detected that there was a small extradural component and the NICI of the dura mater. And following that NICI, we gave a longitudinal dural incision to remove the intradural component. And after removal of the intradural component, we retract the thecal sac medially and notice that there was the small disc, herniated disc material, which have dense adhesion with the ventral dura mater. So we left it with the to avoid the inadvertent injury of the dura. So our final diagnosis was intradural disc herniation, and patient achieved complete neurological recovery at 3 months follow-up. This is my schematic illustration, and I have already reported the case. So next case is a 20-year-old male presented with a lumbago with bilateral sciatica for 1 month. And on examination, SLR is 20 degree on the right side and 60 degree on the left side. And motor and sensory function, no abnormality detected. So this is evident that there's a herniated disc material with downward migration, but there is intensity differences between the migratory component. So in the operation, we have detected that there is a hugely dilated varicose vein. This is the varicose vein, and according to the classification, this is type C epidural varicose vein. That is a dilated vein that totally encircles the nerve root, and we have already reported the cases. This is the schematic diagram we have drawn. in our published cases, and our case falls in type C category. Next case is a 38-year-old male patient with lumbago with left-sided sciatica for 1 month, and on examination, only restricted SLR in the left side, and muscle power become 4 out of 5, EHL and FHL. So in the imaging, if you carefully look, the L4-5 foraminal level, there is a mass. It completely blocks the foramen. So from imaging, it's difficult to diagnose what the mass can be. In the T2-weighted image, there is upward migratory component. So in the axial image, if we look, there is a right paracentral mass. There's two mass separately evident in the T1 weighted image. There is a classical cleavage plane lies between the thecal sac and the mass. And the T2 weighted image, there is two separate dilated ganglion-like structures. So intraoperatively, we detect conjoint nerve root. This is the perioperative picture showing the two nerve roots here, and this is the thecal sac. Next case is a 34-year-old male underwent fenestration and discectomy surgery for PLID L5S1 level 2 times outside our facilities, and for third time he came to our outpatient department with the features of lumbago with right-sided sciatica since his second operation 1 year back. So in the SLR 40-degree right side, and muscle power demonstrated that flexor hallucis longus is 3 out of 5. Patient classically exhibit antalgic gait, and the movement is restricted in all directions, unfortunately. So in the T2-weighted image, that the previous evidence of fenestration, but it's a small herniation of intervertebral disc at the L5S1 level with classical modic changes. In the axial section, there is a mass. We could not detect whether it is nerve root or something else in the T1 weighted image, but there is a cleft, hyperintense cleft in the T1 weighted image axial section. So what happened in the T2 weighted image, that is there is a mass that is hyperintense in the T2 weighted image, and this is the intraop S1 nerve root surrounded by a mass. So what is that mass? We went for L5 laminectomy and classical pedicle screw and rod fixation of L5S1 to decompress the nerve root, and intraoperatively it is evident that there is peridural fibrosis. So we were able to remove the scar tissue from there. So this patient underwent operation 6th March of this month, and the improvement has sciatic pain subsided, but muscle power remains same as preoperative status at 1 week follow-up. So this is probably my last case. It's a 39-year-old female, known case of DM, presented with lumbago with left-sided sciatica for 1 month. On examination, only there is restriction of the straight leg raising test, that is 60 degree. So in the T1 weighted image, there is a tear in the annulus fibrosus, and posterior to the L5S1 level, there is a disc component, and the intensity differs between the migratory component. That is one densely hypointense area noted within the migratory material. And in the T2 weighted image, showing that the fragment that exhibits the isointensity in the T1 weighted image, that is classically hypointense in the T2 weighted image. So we have become a little bit confused what it can be. And the T1 weighted image, that is the axial section, the annulus seems to be, there is bulging, and posterior to it, there is another mass in the left paracentral position. And another axial section demonstrated that there is a detached hypointense migratory component densely adhered with something. Okay, so in the operation, this is the perioperative picture, hugely swollen S1 nerve root. Okay, and after retraction of the nerve root, there is a small disc herniation. We have incised the disc material and to decompress the nerve root, but the migratory component was very small and densely adhered with the nerve root. So to avoid this, the inadvertent injury, we left it behind. We ensured adequate decompression by foraminotomy and wide fenestration. So this case, I have gone for today. My today's case is that. So what is the imaging tips that basically it was a long lecture and it's difficult to memorize all these things. And so let's have a look at what are the imaging tips and tricks we can go for accurate diagnosis of PLID. So what is the suggestive radiological signs of a sequestered disc, that is bullseye sign? Sometimes the sequestered disc have a classical peripheral rim enhancement. So this is known as bullseye sign. Sometimes it can mimic some intradural or extradural lesion, but basically it is a sequestered disc material. So this is another example of a giant sequestered disc, which also classically exhibits the bullseye sign, that is peripheral rim enhancement. After that, for conjoint nerve root diagnosis, there are some classical MRI signs, among which the sagittal shoulder sign, fat crescent sign, and corner sign, that is classically suggestive. Okay. This is sometimes for conjoint nerve root, there can be some other features, like there is widening of the ipsilateral intervertebral foramina, as well as hypoplasia of the facet joint. That is also suggestive. Okay. For intradural disc herniation, the classic sign is Y sign. So if we look at the sagittal MRI, I have already marked the Y. And apart from Y, there are some other features, like the shape is usually beak-like. If we look at the axial sections, a beak-like shape, not all intradural disc herniation can exhibit these features, but sometimes it can be present. Okay. Finally, if we carefully look for flow voids, presence of flow voids in the T288 image, we must go for spinal angiogram, because presence of flow void always indicates some kind of vascular lesion. That is classic features. And I have already marked one of the representative cases where the dot-like and a hugely dilated branch-like flow void present in the spinal canal. So this can be a vascular lesion, and we should go for spinal angiogram. So very rarely, changing neuroimaging features of disc herniation, is it possible? So yes, it can be possible. If we carefully follow up the patient with neuroimaging, we can sort out that there may have some changes in the appearance of the herniated intervertebral disc. Even it can go spontaneous resorption. So how it can happen? Because the herniated disc materials acts as a foreign body in the spinal canal. So it provokes a inflammation in the spinal canal and recruits macrophages within the site of herniation. So the macrophages, this macrophages engulfs the herniated disc material, and with the course of time, it is possible that there may be spontaneous resolution of the herniated disc, and the imaging appearance can be changed. So let's have a look for two examples. This is the images of a T288 section. That is evident that there is a huge herniated disc at the L5S1 level. But what happened in the B and D, this is a follow-up images after 3 months of the similar patient, that there is spontaneous resolution of the herniated disc materials. Okay, so I am almost at the end of my presentation.
But I would like to ask you about this varicose veins, which I do mainly degenerative spine surgery also. I have seen a few cases myself with these big veins that they mimic big herniation on MRI, but when you open, you see big vein which is compressing the nerve root.
Yes.
Do you always try, so my question is, do you always try to coagulate these big veins, because they bleed as hell? I mean, sometimes it gets a lot of bloody, but do you always try to coagulate these veins, or you sometimes just choose to do bone decompression? What is your strategy in these cases?
Okay. In past 3.5 years, I have encountered 4 to 5 cases of spinal epidural varicose vein, and the trouble. One of them was really very troublesome. I didn't able to coagulate all of its course, and after coagulation, there was troublesome bleeding. Okay, and definitely bothers me very in the intraoperative field. So I have already mentioned that I put some surgical ball and able to stop the bleeding. So I was in suspicion that whether patient will recover neurologically or not. I was in suspicion because in first postoperative day, patient still complains of sciatic pain. Uh, Intensity become reduced from his preoperative status, but still have kind of sciatic pain he is suffering from. But in 1 month follow-up, he completely recovers from it. I have already shown these cases in my presentation. There is posteriorly placed a hugely dilated vein that is out of my imagination. I have searched in the literature for the similar cases. I didn't found it. So that was the most bothersome cases in my experience. And remaining 4 cases, yes, I was able to coagulate. I'm fortunate, definitely.
Yeah, yeah. Sometimes they're very it gets a lot of bloody, and
Yes,
sometimes it's but
yes,
yeah.
true.
So my opinion is also that we need to coagulate them because they are big, they compress the nerve root, and not always the bone decompression is
Yes.
the heavy. Okay.